Hello, everyone. We will start the second chest session of our hot seats session of FRCR to Viva. Uh, we will start with our first candidate. Please, my colleagues, today, if anyone want me to give him or to send him privately his score list, I'm ready. So please text me privately if you want to your list. Dr. Roshni, are you ready?
Yes, doctor. Shall I
Uh,
start?
1 minute.
Sorry, shall I start or I have to wait?
No, we'll start. 35 years old male patient uh, complaining of right upper lung zone abnormal auscultation noted by the pulmonologist. Yeah, you
Okay,
can.
I am presented with a frontal radiograph of a chest of a 75-year-old male patient who is presented with a complaint of right upper lobe auscultation problem. Looking at the radiograph, I can see the bilateral hyla appears prominent. Um, the apices are clear. I can see there is an opacity noted at the right paratracheal region. Um,
Yes.
it is it is it is now no it is ill-defined opacity and it is in the right apical region and it is not selecting the paratracheal region. So I think this is in the lung. And apart from that, bilateral hyla appears prominent. There is no any retrocardiac opacity. There is no any pneumothorax or pleural effusion noted. So this can be a consolidation in the right upper lobe, or this can be this can be any opacification in the right upper lobe. So I will proceed with the contrast and CT scan of the chest for further
Can you
characterization.
please, can you compare right upper apical zone with the left apical zone, please?
I can see there are nodular opacity in the right upper zone, but I could not appreciate any pneumothorax or.
Okay, what will you do next?
I will proceed with the contrast and CT scan of the chest.
Okay, this is a contrast, this non-contrast CT scan. Yeah, you can, I will scroll for you.
I have been presented with a CT scan lung window of the chest where I can see there is a significant mediastinal shift towards the right side and there is a reduced right lung volume. Um, there is a relatively hyperlucency on the right side compared to the left lung.
Excellent.
Um, there is a reduced vascularity is also noted on the right side. So I'm thinking of mcleod syndrome in this patient. There are some bronchiectatic changes also noted.
So, what's your differential
So,
diagnosis?
so I am thinking of this can be a mcleod syndrome in this patient, or I could not find any bronchial foreign body within it, which can lead to a collapse of the lung. Apart from that, the hypogenetic lung syndrome is another possibility, but I could not see the any vascular drainage within the inferior vena cava. So, likely this is a mcleod syndrome. I will inform my finding to the referring physician and refer this patient to the respiratory unit for management.
Excellent. Could you tell me what is the pathology of McLeod syndrome?
In which there is an infective etiology due to secondary to some infection, where there is a bronchiolitis,
Mm-hmm.
which leads to a obstruction and air trapping and narrowness as well.
Okay. Excellent, excellent. When the examiner asks you something,
नहीं
يعني
नहीं ऐसे
looks
ही जाना है
looks like irrelevant outside of the film. He wanted, it means he wanted to give you more extra marks. Excellent. Uh, this is 45 years old female patient complaining of dyspnea.
Okay. I have been presented with CT scan axial images of a thorax, soft tissue window of a female patient who was presented with a complaint of dyspnea. Um, I will look through the images, then I will commit my findings. Looking this soft tissue window, the liver and spleen appears normal, and I am going upwards. The basal area of the lung appears normal. I'm going upward, and I can see there is a hilar lymphadenopathy.
What else?
Can you go upward?
What else here?
Can you go upward to see if I see? There is a hilar lymphadenopathy, and
Hmm.
for lung, I will go to the lung window to see the involvement of the lung, and looking at this, I could not find obvious apart from the lymphadenopathy. Okay. Here I am provided with a CT scan axial section of the chest, lung window, where I can see there are multiple bronchiectatic changes are noted within the bilateral lower zone. There is a significant ground glass changes, and fibrotic element are also noted. There is a traction bronchiectasis and ground glass changes. Predominantly are
Also,
located in the subpleural location. So, um, so this is a basal area, and I will look at the esophagus. If it is dilated, this can be secondary to a scleroderma. Um,
excellent. Excellent. I'm waiting for you. Okay.
yeah,
So
here I can see this.
what's your differential diagnosis?
Here I can see the esophagus appears to be dilated, so this is likely a scleroderma. Um, Other differential for this can be a UIP or secondary to a rheumatoid arthritis, but I could not find any. Um, I would look at the chest radiograph and the bones to see the lateral end of the clavicles if there is a resorption, and also if patient have other finding of rheumatoid arthritis, then
Bone is
this.
fine. Bone is fine.
Okay, so this cannot be a rheumatoid arthritis, and I will look the pleural calcified plaques, which can be secondary to asbestosis, which I could not find in this patient.
Dr.
Um,
Roshni, please, some noise come from your side, please.
no, it's
Please.
not from my side.
Please, يعني mute. Candidate, mute yourself, please. My colleagues. And better to close the cameras to allow better connection signal. There are some bodies opening the cameras. Please, please. Okay. يلا. What other differential diagnosis?
The differential diagnosis for this one top differential is a scleroderma, second is a UIP, third is secondary to rheumatoid arthritis, and the fourth is secondary to asbestosis, and the
Which
fifth is
which part
UIP.
of this, which part organ or in this CT could you want to look for to exclude other causes?
To exclude other causes, I have seen the esophagus is dilated, and
Hmm.
um, the so this is confirmed that this is secondary to scleroderma,
Mhm.
and there is no any calcified pleural plaques. The bones appears normal, so this is likely due to scleroderma. So I will immediately inform my finding to the referring physician and refer
Mhm.
this patient to the rheumatology MDT for further management.
Okay. Uh, okay. Uh, third case.
Um, okay, I am provided. I have not provided with history of this patient. Shall I continue?
I will provide you
कटती है
25 years old
इससे
male
प्रोसेस ऑफिस में क्या
patient,
करना
male
चाहिए
patient complaining of dyspnea.
प्लीज आपका
Can you hear me? Unmute yourself, Dr. Roshni, please.
Yes, I am here.
25 years old male patient complaining of dyspnea.
Okay, I have been provided with a frontal radiograph of a 25-year-old male patient who is presented with a complaint of dyspnea. Looking at the radiograph, I can see that there are multiple peripheral based opacities are seen in the left upper zone and also on the right side of the lung. There is a nodal opacity also noted bilateral in the upper zone. There is an interstitial prominent noted on the both side of the lung field. The bilateral hyla appears
What's your differential
normal.
diagnosis? What's your
Uh, the,
differential?
dif-
Hmm.
the differential diagnosis for this is as it is a peripherally located. The top one is can
Hmm.
be cryptogenic organizing pneumonia. Other possibility for this can be eosinophilic pneumonia, and
How can
other is
you
a peripheral.
differentiate? How can you differentiate between of them?
I will correlate with the patient history. If patient have history of some allergic or exposure to certain elements, this can be due to eosinophilic pneumonia. Or
Excellent.
if patients have no history of any kind of this, then this is likely organizing pneumonia. And
Excellent. Hmm.
I will proceed with a CT scan of the chest for further characterization and um, to confirm the diagnosis. I have been present with a CT scan axial of the chest lung window where I can see there are multiple peripheral based opacities are noted within the both apices region and also they are located in the peripheral location. Um,
Yes.
uh, I can see there is some central lucency with surrounding consolidation. So this is likely giving the reverse atoll sign or reverse halo sign and the atoll sign.
So your
So
differential will be,
so this confirm that this is an cryptogenic organizing pneumonia. Um,
look
so I
again,
will.
look again, because not all of them are at all sign. Not all of them. Hmm.
Okay.
If I ask
Uh,
you one test to differentiate between cryptogenic organizing pneumonia and eosinophilic pneumonia, which test will you do?
it,
Very, very basic test.
the
Hmm?
eosinophil on the blood eosinophil level to check
Excellent. Hmm.
if they are
Excellent.
elevated.
Hmm.
And
So,
so I will advise for this test and refer this patient to the respiratory units for management.
excellent. Last case,
Uh, I have been presented with a frontal radiograph of an skeletal image of
53,
the
53 years old patient presented with dyspnea. Hmm.
I have been presented with a frontal radiograph of a 50-year-old patient who is presented with a complaint of dyspnea. Looking at the radiograph, I can see there is an rounded opacity noted in the right mid-zone region. It is a partly well-defined and partly ill-defined. Um, the bilateral hyla appears normal. There's no any pneumothorax or pleural effusion. This can be a consolidation or can be a lung mass. Um, so I will proceed with the contrast and CT scan of the chest.
No, could you give me one differential, differential? Is this consolidation or a mass from X-ray?
As it is a partly well-defined and partly ill-defined, this is likely a lung mass.
Yes. So
So I will proceed with the contrast and CT scan of the chest to further confirm.
CT scan of chest. Okay.
And there is okay.
Yeah, you can
Uh,
proceed.
I have been presented with axial images of an a chest lung window where I can see there is a large opacity noted within the right upper zone. It is associated with the central air lucency and cavitation.
What's your differential
Um,
diagnosis? Because time is up.
the different diagnosis for this cavity lesion, this can be this is likely a lung mass, likely a cavitary lung mass,
So your differential will be,
lung carcinoma in this patient.
what will you do next?
I will advise my finding to the referring physician and refer this patient to the lung MTT for biopsy and for the management and abdomen and pelvis for staging purpose.
What will you do first? You will transfer to MDT or you will do something before?
I will transfer to MDT.
You should do something in your department first
Um,
before transferring. What should you do?
the CT scan of the abdomen and pelvis to look for the metastasis if there is any
Excellent.
metastatic.
What else?
What else? The biopsy I cannot do in my department.
Time is up. Thank you, doctor. Thank you. Uh, you are very confident. You're telling most of the information very rapidly. Uh, Most of the cases you get more than seven, but in these cases, despite you last case, despite you telling the diagnosis correctly, but I will demarcate you to give you 6 from 8. Why? This is not something personally against you, but I want you to get more marks in examination. So
Okay.
um, you tell everything is very good, okay? But first point here, this is a mess. This is very sharp outline here and here. This is a mess. This is not a consolidation. Second point, this is not respect the segmental or the lower anatomy of the lung. خلاص, this is a mess. Second point, you forget to tell this lucency in X-ray. So from X-ray, an upper and middle right lung zone with central mass with central cavitation, most probably cavitating lung mass. I will do CT scan. Second point, uh, in the 4 cases, you made one mistake. You didn't mention the technique. This is axial, sagittal, coronal, post-contrast, non-contrast. None of the 4 cases you didn't mention the technique. Okay, no problem. We are here training. So we are يعني we learn it from each other. This is post-contrast CT scan of the chest. This is axial lung window, cavitating lung mass. Okay, almost
Yes.
infiltrating the right hilum. This is also important sign. If I am in your shoes, I will tell. However, there are no obvious upper lobar collapse. Second point, I think there are some element of interloper thickening here. This is not a big issue, but the most important, the management. The most important, the management. Why? Before you transfer to MDT, you should mention, I will do a staging CT scan of the abdomen and pelvis. And I will arrange for, not for biopsy first. The first now is a PET CT, not biopsy. Why?
Okay.
Because there are here in the normal, usual, the conventional CT, we don't know the true active tissue, malignant tissue from the necrotic tissue. So PET CT now is a must in NHS to target the biopsy. This is very important now, my colleagues, to mention in all chest, in all bronchogenic carcinoma. I will do staging CT scan and then I will do PET CT. Both of them are now requested. PET CT first indication for it targeted the active tissue for a true, a correct biopsy in biopsy needle insertion. Second, to detect the hidden metastatic deposit. Okay, this is all. This case you did very well, except the management. Also, we should mention here the mass is not separable from the chest wall, However, I couldn't detect any rib destruction. The third case, this one, I think you did very well, except you didn't mention I will do CPC to confirm if there are xenophilia or not. It will help you because we are a clinician, not just radiologist. But I think you did very well. Case before that, uh, this case is very good and very easy, but you take at least 2 minutes, and I'm going up and down, up and down. I'm trying to concentrate at this. This is dilated esophagus in FRCR examination and chest. خلاص, you should see this. خلاص, my diagnosis is almost non-specific interstitial or whatever interstitial lung disease due to scleroderma. Second, I ask you one question. You didn't, I think you didn't get it at all. I ask you, from this CT, could you differentiate other causes of this interstitial lung disease other than scleroderma? You should tell me, oh, doctor, this heart looks like normal, no calcification, no stent. And also this liver density looks normal, so I will exclude amiodarone toxicity. I'm waiting to you specifically for this. This is very important. By the way, I got case same like this, and the liver was density. It was not scleroderma, but the liver density was very high. You tell very well there are no. I should see the clavicle, which I immediately told you. This is the bone is unremarkable. First case, this is startup case. It was Swyer-James syndrome or McLeod syndrome. Uh, you tell very well. I give you 7.5 in the first case. But I'm waiting also for you. I will ask for old images because McLeod or Swyer-James is a chronic condition since childhood. Overall, Dr. Roshni, like before, you did very well and you are confident. Thank you very much.
Thank you.
Dr.
Thank you.
Miga, who is the first candidate?
Yeah. Yeah, could you please show the X-ray of this case first, please? Yeah, okay. Thank you.
What do you see? Yeah, there are
Oh,
hyperlucency here, hyperlucency and some reticulation. To be honest, there are mild volume loss here because see, this is right side of the heart is larger than the normal. We just in the usual normal X-ray just see some strip. I think half of it. So also you should mention at least I suspect. If you tell I suspect there are some volume loss, يعني it will not make any harmful for you. But overall, very good. Dr. Miga, who is the second candidate?
second is Dr. Akida.
She is ready?
Yes, I think yes.
Yes, I'm here. Can you hear me?
Okay. Sorry, I will mute anyone other than the candidate, please, to make the maximum. Dr. Miga, could you make a time limit, 15-minute time limit,
Yes,
please?
yes.
Okay. Dr. Akira, are you ready?
Yes, sir. Good
Okay.
morning. Sorry,
Good
good evening to
morning.
you.
Good evening. 35 years old patient, post-trauma.
Post-trauma?
Yes.
Okay. Okay, XHS frontal projection of a 55-year-old male presented with trauma. Here I can appreciate diffuse opacity involving the left lower hemithorax. I cannot appreciate left semi-diaphragm. However, the cardiac size appear normal. Um, The upper visualized left lung also appear heterogeneously opaque, and there is mild mediastinal shift toward the contralateral side. The right lung and the right hemidiaphragm grossly appear unremarkable. Right hilum also appear unremarkable. Um, Sorry, I forgot to mention the lines. I think there are few chest leads and one of the NG tube. I can see tip of the NG tube, which is projecting towards the left hemithorax. Um, and also I can appreciate multiple rib fractures along the left lateral chest wall, and I think few of the ribs are broken at 2 points.
What your
So this
differential
is
diagnosis?
so there is a post-traumatic fracture leading to a lung contusion, and maybe suspicion of the left diaphragmatic fracture as well. So I would immediately inform my findings to the clinical team and would suggest CT post-contrast if the patient is stable hemodynamically.
What will you do
For
next? What will you do
Sir, if the
next?
patient is hemodynamically, if the patient is stable, and after informing the clinical team, I would suggest contrast enhanced CT chest and abdomen
Mm-hmm.
for further evaluation.
What you
Because
are worried about?
sir, because there is a suspicion of a diaphragmatic left diaphragmatic rupture, and also there is
Excellent.
flared
Okay,
chest
okay. If I
paired
told
with the
you this
lung.
is, if I told you this is a polytrauma patient, what
Yes.
also you should look at, important to look at in the post-contrast CT, other than this fracture and this diaphragm.
Vascular, I mean, if there is any active bleeder, that is
Okay.
most important thing to know. Aorta,
O-
thoracic and abdominal aorta, and all the major visceral vessels should be evaluated immediately.
If I show you this also, this is the pelvis of the same patient.
Okay, so this is a frontal view of pelvis X-ray, including the proximal femora as well, of the same patient with post-traumatic. There are multiple fractures involving the left hemipelvis,
Mm-hmm.
as well as the right pubic inferior pubic ramus, and also the acetabular. I think acetabular. The alveopectineal line on the right side is also slightly,
Two
interrupted.
hour ago, 2 hour ago, the patient developed severe dyspnea. What are you worried
Uh,
about?
Pulmonary embolism would be
Excellent.
the first thought.
What type of embolism?
It can be fat embolism because of the
Excellent. Mm,
fracture, bone
okay.
fracture.
Excellent. Next case.
ऐसा सबसे पहले ब्लैक ऐसा पर्पल वाला इतना नहीं है ऐसा कुछ होता है दोनों में
30 years old
ऐसा
female
दूंगा मैं
patient complaining of dyspnea.
हम भी ऐसे परेश करेंगे
Only available
Male,
this female.
okay, female patient.
Yes.
Okay, 30-year female patient with dyspnea. This is CT coronal view, lung window. I can appreciate the most striking feature are multiple very small size cysts diffusely scattered in the bilateral lung parenchyma. There is no zonal predilection. Um, I can appreciate few areas of septal thickening in the lung bases.
What's your
No
differential diagnosis?
no pleural effusion or pneumothoraces. So multiple. I think first thought would be LAM if the patient is a known case of tuberous sclerosis. If I would, if not, then I would suggest a comparison with the previous film, and also an abdominal ultrasound for
What will you do
related
next?
associated findings.
What will you do next?
Abdominal scan or ultrasound, whatever I can do.
If I choose use this lower upper cuts of upper abdomen,
Mm.
would you see it well?
It's the same patient.
Yes.
Okay. Um,
Hmm.
um, I'm looking at the liver and kidneys. The liver appear normal with smooth margins.
Hmm.
I cannot appreciate any focal lesion on this
Hmm.
provided image. And bilateral kidneys. I would like to review the kidneys because I have some
Look
suspicion
at the
that.
kidneys. Look at the
Yeah,
concentrate on the kidney, please.
yeah,
To
I'm looking.
detect.
Can you please scroll, sir? I want to see it from top to bottom. Kidneys
Yeah,
from
yeah.
top to
No, no,
bottom.
no. Don't worry about
Okay,
the rest of the kidneys. Look at this
okay,
slice,
okay.
please.
I can appreciate a very tiny areas of low density in the right kidney as well as
What?
few smaller on the left side.
What?
I suspect AML angiomyolipomas uh, on
Final
this
diagnosis, please.
uh,
Your final
tuberous
diagnosis.
sclerosis, tuberous
Ex
sclerosis with small angiomyolipomas and lamb in the chest.
Excellent. 40 years old male patient with severe dyspnea.
40-year-old male patient, X-ray chest frontal projection of 40-year-old male patient with acute dyspnea.
वो देखो बच्चा क्या कह रहा
Yes.
है
Okay, acute dyspnea. Uh, I'm
ये
looking.
but some
Here I can appreciate multiple lucent lines along the superior mediastinum extending into the neck. I can also appreciate a subcutaneous emphysema in the right supraclavicular region, and I can also appreciate a lucent line along the base of the heart, which is giving the appearance of a continuous diaphragm sign. So my
Excellent.
strong suspicion is of an hemomediastinum with the subcutaneous emphysema. Uh, However,
What is
I
the most
cannot appreciate pneumothorax.
what is the most common cause of pneumomediastinum?
Pneumomediastinum, it could be a tracheal bronchial rupture.
Yes,
Uh,
but I'm asking about the most common.
um,
No problem.
uh,
No
Sorry,
problem.
it is
Okay.
like
What will you do next?
mm, I say
For Hmm.
I would first of all I would inform the clinical team and then would suggest CT, chest and upper abdomen for the evaluation and to rule out the cause if there is any tracheobronchial rupture or any lower abdominal cause leading to this pneumomediastinum.
बच्चे आ गए थे
Excellent.
Yes.
55 years old
Um,
male patient with acute exacerbation of shortness of breath in the cuff.
Acute shortness of breath. 55-year-old male patient with acute shortness of breath and cough. This is frontal chest X-ray.
Mm.
Here I can appreciate grossly enlarged heart size and bilateral opacities in the mid and lower zone uh, in both the hemithoraces. Um,
Mm-hmm.
mm, the right CP angle is clearly visible. However, the left is not clearly outlined. There is suspicion of pleural thickening or airspace opacification. And I can also
आज एक धूप है पहले
What's your
very
diagnosis?
acute. Um, there is no history of trauma.
No
Um,
history of trauma.
no any intervention.
No.
No intervention.
We have just 1 minute, huh? Zoom will shut down. 55 years old patient, male patient of acute on top of chronic dyspnea. What is the name of this appearance of this chest
This
X-ray?
could be alveolar proteinosis. I think the differential alveolar pulmonary
What
alveolar
else?
proteinosis or
Okay, what
uh,
else?
a microlithiasis less likely. It can be congestive heart failure. and
Yes, look at the heart.
non-cardiogenic, no, non-cardiogenic and cardiogenic. Most of all, top of the I think cardiogenic causes, and then non-cardiogenic as well.
Okay, what is
Compatible
the
with the
name
previous one.
what is the name of this sign? Perihilar ossification, bilateral,
Bad
more
wings,
the
bad wings,
bat
bad wing
wing.
sign.
Yeah. Okay, excellent. My colleagues, let's join the another link because Zoom now will shut down within 1 minute. I will finish this case now. Excellent, doctor. Except in this last case, I will give you 6/8 because it was very easy case and you missed the backup from the beginning. But no, don't worry. This is a mental block and this is very common for all of us. Sometimes the examiner give us very easy case, but however we are looking apathetic in front of him. Don't worry. This is a case. I give you a good history. Look at the heart. The heart is enlarged. There are bilateral, perihilar opacification. Looks like